we're just going to share our slides now. Okay, great. That's brilliant. So hope everyone is logged in okay. It's actually 1 o'clock. So what we're going to do is we're going to get going now. I've got Gail sitting here beside me. Hopefully people can see us on the screen. So thanks a million to everyone for joining, and welcome to our 4th QI Talk Time of an exciting lineup of QI Talk Time webinar sessions in 2017. QI Talk Time provides an opportunity for colleagues across health and social care professionals and settings to learn from leaders in improvement, innovation and integration. So I'm delighted to have Gail Nielsen here with us today. She's based in Des Moines. It's hard to pronounce. It's a French name in Iowa, which is 6 hours west of Chicago. Gail has 17 years experience working with healthcare staff at all levels of organization to enable teams to remove barriers and accelerate change. She's a Harvard Fellow. She works with the IHI and has consulted in many other countries and has worked across a number of programs, for example, person-centered care and transitioning from acute to non-acute settings. So just a few housekeeping notifications. So you'll see we want to make it as interactive as possible. So if you go up to the top right-hand corner, you'll see a chat box. Click on that and make it blue, and it means then that you can chat by typing into the chat box at the bottom of the screen. Please, when you're typing into that, type send to everybody so that everyone can see. So click all participants when you're doing that. That'd be great. The sound, you can listen through your computer, or you can also dial in. The sound dialing in should be much better, actually. So if you can do that, that would be good. So keep the comments, questions, and ideas coming. And if you can let us know if you're in a group, how many people are in the group, that would be great. We're going to have some time at the end for questions and answers, so keep them coming throughout. I'll be keeping an eye on the chat box, and then Gail will answer those questions at the end of her talk. We will have some attendance certs that we can send to people if you want to type in your email address in the chat box, and we can send those on afterwards. So now, without further ado, I'm handing over to Gail, who'll take us through her presentation. Thanks a million, Gail.
Well, thank you. Hello, everyone. It's actually exciting for me to be here with you today because this is the kind of work that I have done for my teams back home for about 13 years. I ran a large improvement operation across multiple hospitals, multiple states, office practices, home care agencies, and we had people who'd been trained, like yourself, and they were desperate to continue learning together over time, and so it's fun to be doing this for you today. We want to work on these things today. I've been hearing that you're really feeling a little bit of burnout, maybe a lot of burnout, so we're going to introduce that topic, but we're going to move on so that I can address some of the questions you've been talking about with each other, working with senior leaders, but also influencing improvements with the teams. First of all, I'd like to encourage you to take this advice. You know, it's interesting how easy it is for us to forget that ourselves and our personal well-being and our physiological health are very important, and we get busy working on things, and more work is on our plate, and we forget. So let's talk a little bit first about burnout. And in the case of burnout, we should think about it not just for ourselves, but when burnout is present, it really interferes with patient safety, and it's difficult for us to provide compassionate care or even to be compassionate with the peers who work beside us. Well, burnout doesn't mean that you're lazy, although when people are burned out, they may change their behaviors in such a way that we might think that they're lazy or that they're avoiding something or someone. So we need to be careful about that, and we want to begin to think about how do we turn that around? How do we begin to address resilience? And we'd like to start that with you today on a more individual and a little bit of an interpersonal interactions. It does have a scope that goes all the way to the strategic programs of an organization, but let's start with ourselves and each other. Well, how do we build resilience? This is an example from Mayo Clinic. It's a program that they've included with their development of physicians and addressing burnout in their organization. And what they're looking at here is that there are 12 different ways that we can really build resilience in ourselves. So in these 12, there are things like forgiveness, eating portion sizes, thinking about our habits and preventive medicine, testing, getting adequate sleep. And, you know, one of the things we think we can get away with having less and less sleep, but sleep is a very important part of our physiology when it comes to mitigating the bad things that hit us in the face many times every day. So get more sleep will help you. Try new things. Find ways to induce laughter, spend time with families and friends, quiet our minds, and we'll also talk just a little bit about gratitude. So one of the things I'd like to challenge you with, and maybe you can do this between now and your next QI Talk Time, is to think about reconnecting with your body, taking time to smile and greet each other, and then to write down inspiring patient stories. You know, patient stories actually help us influence others and help us get results faster, but they also feed that inner positive hunger that we have for going towards the positive and trying to mitigate the negative things that pile upon us every day. And don't forget to have fun. But I want to talk a little bit more about reconnecting with our bodies. One of the things that I've begun to understand over time, and I hear a lot about this from Dr. Brian Sexton from the Duke University Patient Safety Center. He reminds us that we really need to be careful about that because we often think that we can do without food, that we can delay eating. That actually begins to cause stresses that are insidious inside us, and we think we're not hungry, but it actually undermines our physical strength. Once our physical strength begins to be undermined, the mental power and energy also dwindles. So things seem worse to us in that state. So Dr. Sexton says that we need to pay attention to eating, sleeping, and peeing. Now that may sound kind of funny to you, but I'm thinking that particularly with nurses and sometimes with doctors and other people who are very busy, we congratulate ourselves, especially when we're in training, we congratulate ourselves for having a great big bladder and that we don't have to take time out to go and empty that. But we've lost track of what that impact is because we've ignored it for so long that we don't realize the stress that is building within it. So think about reconnecting with your body. The gratitude diaries is just one example of the many good things that are out there in the world, but I brought you a few things today that I think are some of the best of the best. Well, one of the things about burnout, resilience, being a focus across the world today is that everybody's kind of jumping on the bandwagon. Everyone thinks they want to be in this space, to sell a product, for instance. So I'm just bringing you my favorites. The gratitude diaries reminds us that we should be looking for the good things in our life, that we need to figure out ways to appreciate as often as we can during the day, and especially in the evening to reflect on our gratitude at positive ideas. Here's another. Dr. Martin Seligman really was profound in his development of this idea of flourishing and the understanding of happiness, which relates to well-being. His recommendation that we found very powerful is to daily reflect on at least 3 good things, the good things that we experienced today. And so how this works is that he recommends that we do this in the evening between supper time and bedtime. And the reason he recommends the evening is that when we sleep, the physiological reality is that our brain actually keeps working. And it works on mitigating the bad and filing things away. And when we can reflect on good things in the evening, they're in the forefront of our memory as our brain does its work in the night. So we just get a little extra boost from the evening. I know that you can do it any time of day. I have friends and colleagues, family members who have done this reflection at other times of day, coming to work, on the train, or in your car. Might be a good time because you are alone and can reflect quietly.
Just to interrupt you there, Rob actually has just typed in, a useful tip is introducing your kids to the concept of reflecting on 3 good things before bedtime, and they'll remind you to do it too. So yeah. It's a good...
Absolutely.
Yeah.
Absolutely. Another time, my daughters both have young children, and they have gotten into the habit at dinner time around the table, which they pretty much hold pretty sacred. Family sits down together in the evening, and then they go around the table. And that's how they've introduced their children to it, is at mealtime. So that mealtime is a happy time and not, just the frustration of trying to get through a meal and getting ready for bed. So the 3 good things has come to be very, very important. And Dr. Brian Sexton, as I mentioned, he's from Duke University, Patient Safety Center, has been incorporating this 3 good things and building resilience into his patient safety work across the nation. And he started to measure the impact. And what I can tell you that he knows today, although this work is not yet published, is he's proven that doing the habitual 3 good things is better than Prozac. And so it's a lot cheaper. And so what happens when you do 3 good things is that you begin to notice that if you can get the habit, that in just a few weeks you'll begin to notice that you're sleeping better. And then you'll notice that you feel more energy during the day, and you begin to reflect on the 3 good things. You'll notice the things as they're happening, which actually also increases their impact. So think about 3 good things. This may be one of the things you'd like to try. And really the only challenge with it is how to make it reliable that we do it on a regular basis.
And sorry, Gail, just to interrupt, is that something that you could do as part of a team?
Absolutely.
You could do that like on a weekly basis or something like that in a team meeting to try and bring in that type of science into the way teams work.
Yes, and so actually it's not advancing the slide.
All right, okay.
Let's try it. Because on the next slide, you must be prophetic. Here is an example. Now, this is another author, but she recommends that you do this in meetings. And maybe it's even just 1 good thing. So I have a hospital here in Dublin who's been practicing on this, and I'm going to do a workshop about resilience for them on Friday. But that's one of the things that they've been doing is to change up their meetings so that they're reflecting together. They go around to say that each person would share 1 good thing that happened to me that I'd like to share that happened since we met last. It may be about a patient, it may be about their own lives, but how that impact has impressed upon them. And so in that meeting, you maybe just shared 1 good thing, but maybe there are 5 or 10 or 15 people there, and every one of those good things usually is a positive impact on us. And the reason this is so important is from Barbara Fredrickson in this book. She points out this, the problems of bad things and how much it takes to mitigate those to the good. So it takes 3 good things to mitigate 1 bad thing. So if you pause a moment and think about maybe even just how often today something that bothered you, something that wasn't quite right, maybe someone was unhappy, whatever it was, that it wasn't a positive thing. And if you have 5 or 10 or 20 of those by noon, I think we need to work on this idea of having some good things that are in our mind, that we share it with others, And so the first paragraph here is about let's share something during a meeting. And secondly, how can we help to remove barriers, or maybe it's safety defects or something that this team is concerned about. So if we're asking the team, it may be that we can begin to work on something that aggravates us, that's waste and frustration, so that doesn't hit us every day in the future. All right, so let's move now to some of the things that I think have been weighing on your souls and your minds, to give you some ideas from my experience over these many years about how I've been able to move teams forward to do things a little faster and things that are quite practical. Now, one of the things that I find that has helped my career actually the most is learning how to manage up, how to manage my boss, and how to connect with my boss or my senior leader who's sponsoring a project that either I or a team I'm coaching may be involved with. So here are the things I have found that are the most critical. First of all, identify who that senior leader is who's responsible for that project. Perhaps it's a vice president. In my case, it was a number of CEOs and vice presidents. But maybe you can't get to them to report out, but you're preparing your boss, your director, your division leader, who would report to that highest member. So you need to make it easy for them to tell the right story, the best story, to their leader, who is the executive accountable for this initiative. So get on the calendar. And then how do you get on the calendar? So what you'll find often is that you have an appointment this month, and you're making an appointment every month, but for months in a row, the meeting gets canceled. So here's how I do that. I build a relationship with those executive administrative assistants, and I tell them this meeting cannot be canceled. The meeting can be rescheduled, but not canceled. Because what happens when the first one gets missed, and then the next one gets missed, and the next one gets missed, this is a problem for your progress and your project. So we can reschedule them, but we can't miss 2 or 3 in a row. So working with an administrative assistant, there are lots of little treats and, bring them a surprise. Just smile a lot, be kind with them, and you will find that they'll figure out how you can be on that schedule on a regular basis. Then when you have your meeting, be very prepared, have everything concisely prepared for your review. You can do this in 15 minutes, 20 minutes, if it's hard to get on their calendar. I like a half an hour, but you're talking to them about your progress, milestones, and also your results so far. But also, there are other things that we want to do. We want to make sure that we're sharing with them the things that aren't going so well, and to be frank about that. And we'll come back to that in just a moment. But first of all, I want to make sure that you know that you have approval on a charter. And the charter might be changed, but you'll need approval from that executive. Then begin to coach towards what you need from them. So this is the managing up part. We want them to be at specific places sometimes. It helps your team to sprout their wings and have more energy if that senior sponsor will show up once in a while. Maybe it's for 2 minutes, maybe it's 5 minutes, maybe it's for 10. And across my organization, we met in different places in our organization, so that's across a number of states. And when I would be hosting a meeting for improvement at one of those other facilities, I would phone up the CEO and tell them I needed them on that date. And sometimes they weren't there, and we decided who would be their surrogate, but almost always they just happened to be available. And so I made sure that I let them know what we've been doing, what is our progress, what might we need from them, and then I would give them 2, 3, 4 talking points about what I'd like them to share. So I'd like them to share, congratulations, thank you for your work. This is really important work. Here's how it fits to the executive strategic plan. and then just thank them. They can be there for 10 minutes, but it makes such an impression on the people who work there, who are participating in this work. It gives them energy. So one of my stories is that I've done this a lot, and CEOs show up, and was working with teams who had been together for 10 years, working on reducing falls and related injuries in all of our hospitals. And at the 10th year marker, we gave the report to the board of directors of the system, and it showed that we had eliminated over 6,000 falls within the walls of our hospitals. Granted, these are quite a few hospitals, but 6,000 is quite a number, and we had reduced the related falls with injury to very, very few, and that there were hospitals that had gone for 2 years or more where they didn't have a fall with serious injuries. And that board told the CEO that they wanted to hear about a celebration that we should be having about that. So we mounted the celebration, and the CEO came to that meeting to give us greetings once more and congratulations from the board of directors. He also gave a plaque to each of the teams. And at that meeting, a young woman, a nurse, stood up, and she said to the CEO, "Thank you for being here. I wanted you to know that your participation with us, your attention, and that of the board of directors was the wind beneath our wings." And I could see it time after time after time that when the CEO or their executive sponsor for a team showed up, that it made a difference. It helped remind them what good work they were doing and how important this was. It doesn't hurt to ask, but be sure to make it easy for them to do, like the message that I mentioned to you, which is tell them what information it would be good for them to share, and make sure you tell them your progress so far. So certainly we want them to cheer on the team and also to be there when we celebrate results. So I mentioned charter, and one of the things I find is that charters are often pages long, and what I want you to have is a charter that's simple, that is pretty focused, and it's something on one page that you can put in front of your team each time you meet. And the reason is that so often the team will be in its work and learning many things from tests of change, and they get all excited about something they learned, but you realize that it's really a bit off course from the core focus of your aim. And so in that case, you want to be able to say to them that we need to park that in a parking lot, or maybe someone else can work on that while we continue to stay clear to our focus. When you have this paper in front of you, it's easier for you to point that out to them and ask them, let's set this aside right now. And so you would identify the aim, how much by when, and then we would mention something about where we were when we started. We would also say, where does this process begin and end, so that we're clear about what we're not working on, and then we identify our measures. On the right-hand side, it's the timeline, when do we want to achieve our aim, and then to say who are the participants there. Here's an example of one of mine. This one was about reducing the unplanned readmissions or avoidable readmissions within 30 days to our hospitals. As you can see that we've described that aim and talked about how it would work. We mentioned what the rate of readmissions was at that time and how much we wanted to improve it, and then also mentioned a target from the Institute for Healthcare Improvement. We described the focus and boundaries, and then we laid out our measures, and you can see that we have the team members. I have found that this gives me power to direct the discussion and keep people on track. It also begins to talk to us about what are we doing for the patients, the service users, whoever our client is, that what's important to them. So one of the things I'm very intent on is when I start my aim statement, I always say how it's going to make something better for the people in our care. So is it our patients? Is it a service user? What will be different from them, for them? And so we're saying here that we are going to reduce unplanned readmissions for patients. We can go on to say the reason that's so important is that has to do with patient safety and patient experience. So now a little bit more about working with your senior leaders. You can use your influence to achieve results. And one of those things has to do about expectations of roles and others' roles. I'm going to tell you a story when I get a little deeper into this slide that will help you understand some of these more clearly. But one of the things we want to do is to be frank about barriers. If we keep ignoring the barriers because we don't want to bring bad news to our bosses or executives or others, we're not going to make progress. But when we talk about barriers, we should also come with some ideas of possible things that might help so that we can, some people, we tell them barriers and they don't know what to do. They're not involved in the kind of upfront operations that we might be in our team work. And this idea of hint and hope really doesn't work. So we want to be sure that we're pushing for who can do what by when, and we're asking the senior leader. So here again, we're managing the senior leader who are sponsor of this team by asking what's possible by when, including that in all of the meeting notes and reports, and then be careful about this idea of the blame game. When someone can't get something done by when they say, we need to find out more about that, because you know that it's hard for busy people with so much on their plates to prioritize and memorize something. So here's my story. This was a typical story. My role for helping coach teams and their leaders, I would, whenever I could, I would stop by my various hospitals and I would meet with some of the coaches on a one-to-one basis to see where they were and how they were stuck. And during those conversations, some things would come up as a surprise to me. In this case, I was at Allen Hospital in Waterloo, Iowa, and I was working with Jane, who was a nurse manager, a very busy, productive, respected ward in her hospital. And she's telling me during this meeting that she can no longer be the leader. And I asked her if she had told Dr. Crandall this, who was her senior leader, or what she had been telling him about what was difficult for her. And she said she had not. She had not told him, but she realized she was going to have to tell him at her meeting with him today she could no longer lead this important initiative. So I went to the meeting with her, and I found that she's talking along, and she's really avoiding this truth that she knows she's going to have to tell him, and now we're running out of time. So finally, I said, you know, you have something important to say today, and you need to be saying this before the end of the meeting, so give him the bad news. So Dr. Crandall heard that she could no longer do this, but he said to her, oh no, you are a wonderful leader. You have such wonderful skills. People respect you. How can I help? Is there anything I could possibly do to help you stay in this role? She was quiet for a little bit, but she said, you know, there is something. She said, one of the things that, she said, I'm so busy that I can't find myself coming and going. But she said, if I could have someone help with the actual recording of the notes and the things that we need to report out, she said, it'd be almost like a secretary or something. She says, I just can't do the work of improvement and take care of my unit and then type up all this stuff that we're supposed to be providing to the rest of the organization. So he said, oh, are you telling me that if I could find someone to do that for you, that you might be able to stay? And she said, yes, I think I can do that. Is that possible? Can you do that? And he said, well, interesting that someone just told me yesterday that there was one of the receptionists who actually wanted to know if there was any other work, small pieces of work that we could give this person because they were interested in filling in some of the gaps when they had a little spare time. And so they were ready to leave the room, but I asked them to pause. I needed to know from Dr. Crandall when he could get back to her about whether this was really going to be possible with this individual and how it might work. And he said to her, I think I could do it in the next couple of days, but if I tell you a week from today, will that be okay? And she agreed to that. And then he said, what if I give you one of my dictation devices, and then she can just type it up from there because she does that for me all the time. So they had an agreement. He got back to her in 3 days, and they moved along. So it's just one example. Another example is this senior sponsor was the nursing executive of the hospital, and the team is working on ventilator-associated pneumonia, and they wanted central line infection because they wanted to sample little gel packs of hand cleaner that would be attached to the top of the sterile pack so that they didn't have to tell the doctor to go back out and wash his hands, right? So the team went to purchasing to get us some samples of these to see if that would work because they didn't want to buy a big lot of this and they didn't want to go through the new purchase process. In that hospital, you couldn't buy something new without going through a committee, but all they wanted was a few because they didn't want to buy them if it didn't change the dynamics in the patient's room. So they were telling the nurse exec that they were really disappointed that they couldn't test this great new idea that they had discovered. And so the nurse exec walked down to purchasing and she said, I'm asking you to do this time. I promise you that I will see that they get all the paperwork in the committee request completed. If it works, get us one box. They'll run the test of change. If we want more, we will go through the process. And so she made it happen. And you know what? It was a wonderful solution. The physicians loved it. The nurses loved it because they never again had to say, go wash your hands. I didn't see you wash your hands. So it's really important to be able to say what the problems are and to be frank about that. So a little bit more about accelerating change. So one of the things I find is most valuable when we see that we're working on a process, but it isn't quite reliable yet, and we want to make it better and better over time, is just go see it. Nothing replaces our observation of the process. Now, you may be working on something that's a little harder to observe, but I would say that if there's any way you can go, even if you have to spend half a day, usually it doesn't take that long to observe the process. Another is this idea of understanding the roots of a problem before we try testing changes. I know that I can change almost anything in the world using PDSA, and my colleagues who have a lot of experience with PDSA can do that too. But I find that people with less experience, a new person using it, may get worn out because they're using the PDSAs and it doesn't work. The PDSAs, whatever they're trying, it just doesn't work, so they give up. Well, if we ask why and get down into the root of the problem before we start testing, we're more likely to go quickly because we're actually adjusting the roots of the problem, not the symptoms that we've been noticing in the beginning. So I'll give you an example. A nurse walks into a patient's room and he says, I called you. I needed to go to the bathroom, and you didn't come. My bed is wet. So she was quite shocked, felt bad, and so she said to him, I'm so sorry. Let me get you cleaned up right away. And while she was doing that, she said, I didn't get your call. Now, in this case, the call at the patient's bedside would ring a vocera. It's a phone that hangs around the nurse's neck, and then she could just quickly respond by touching it. She never got that call. So she started digging in. Now, if we stopped at the very beginning then it's like, was the nurse lazy? What was going on? It's a blame game at the beginning. It's about the nurse. But this nurse knew ask why 5 times, so she started digging in, and she told her manager what happened, and she said, I'm going to call the biomed tech from downstairs to come and check this room. He checked the room and found it to be a malfunctioning call light. And they kept going. They eventually, long story short, they tested all of the call lights in that floor and 2 other floors that her manager managed, and they found out that 30% of the call lights were not functioning on any unit, and 50% of the falls in the hospital were happening in the 30% of the rooms. So they ended up changing a process across a whole health system about how do they manage the malfunctioning call lights. And so you see that if they had tried to test on some of the superficial issues of that problem, they never would have discovered a profound problem about electronic devices. So that's just one thing that you might like to try. Another is to make sure that you're getting the difference between testing changes and then hardwiring them or implementing them. So that hardwiring or implementation really is a whole other set of work. Once we know that this thing that we're testing can work, to make it permanent it takes also a lot of work, because you need to test to make sure that you can sustain it over time. So I think you already know that that means that you're going to be making sure that people are well-trained, that not just the existing people are trained, but how do we train new people who come into this work, and that we may need to put it in policy procedure, describe it really well. How does it connect to any things that we may need, adjustments of the IT system, whatever that will make it easy to do it always. The next one is to make sure that we're using PDSI cycles for what works and what doesn't. So one of the things I find is I like to test the ideas of the people who do the work, not the ideas that someone brought to me from outside of the unit or outside of the organization, but what the people what they're doing the work. They know the work better than anyone, and so we test their ideas and can make a difference. So what I find is that when we're asking them about their ideas, sometimes we'll end up with 5 or 6 different ideas, and they may be competing ideas. So one of the things that we do is we call it shopping the ideas. So let's say that we're in a doctor's clinic or we're on a nursing unit, and we take this list of ideas and we go round to as many people as we can get to in 10 or 15 minutes and say, here's the problem, here are the ideas that people have suggested, which one shall we test first? And then tell me why or why not some of these, and which ones, why would you do these and not those? And it's amazing that when I've gone with nurse managers who are running this little shopping expedition, they always go with this idea that they know which one's going to be picked, and they should just be able to just go do it themselves, So what I find is that they're often wrong. And when they hear the rationale about why we should test this one and not that one, it makes sense to them. And so what happens in that story is that the people then know what's going on. They know that ideas from the unit are being tested. They had a say in which one we test first. We may never get to that, some of those tests, but we'll start with something, and if that's working, then we can just continue doing that test. But it creates some more buy-in. People are excited to see that you're paying attention to what they think and their ideas for change. Do more testing. I'm hoping that you know that many small tests make a difference, and that if you can do it at least a number of times a week, if not daily, because we know that the more cycles that teams run, those teams have better success. So I think you know all of this PDSA. I would just say that the piece that I didn't understand at the beginning when I was new at this work was the value of the prediction. If we predict what will happen, then we can test against that. We can study against that to see if our predictions were correct, because a prediction that wasn't correct gives us even deeper knowledge than if we just took a look at the things that occurred. Other things that you might think about is starting with volunteers rather than those people who don't like this idea. We don't wait to get buy-in for the small tests of change, so realize that you don't need buy-in just from a few people to try really small tests. And then, if it works for those people, it may be easier to build your consensus as you get larger and larger tests afoot. Sometimes just be innovative, and one way to be innovative is ask the patients and families what they think might work. Also, the idea is a little data for each test, and the very first test, one of my measures is, would you test again? I'm asking you to do a test, and if that person tells me that they would run the next test, I have more confidence that I'm in the right direction, so that might be useful to you. Of course, you know this, test over a wide range of conditions, day, night, time of day, day of week, who's in the process at the time, and think several cycles ahead. So you may be testing, maybe you're testing how you would use the process of teach-back. So asking patients to say what they just heard about something important you've told them. And you're testing with one nurse today. So if it works for her, who might you ask next? And would she suggest someone thinking about how you're going to get to the next 2 or 3 cycles and how you might get from one shift to the second shift, et cetera. Also, some things we can't observe, but we can simulate if we really need that. So some things about your team. Here's a little bit again about the staying on purpose, that having the charter, which has your aim statement on it, reviewing the aim for them, and certainly this idea of the greater good. Remember what I said about my aim statement? I like this aim statement's first sentence to say that this is what's important to the patient and family. Are we reducing pain? Are we reducing injury? Are we improving patient safety? Are we improving their experience of care? Those statements are things that touch the heart, not just the mind, and help build buy-in. So how do we do some of that? Telling stories. Was it about wasted resources, patients, exhaustion, frustrated staff? What all kinds of things might help us tell that story? And then make sure that when our team is floundering a bit, that we go back. I like to go back and have a chat with my senior leader about reviewing the strategic focus and reconnecting to what's important to the organization, to the patients and families in our care. And that does help us talk to our team. And then, because sometimes we get lost, the team gets so, would you say, overwrought, that we are now overwrought, and we've sort of lost our own vision. But the senior leader can help us very quickly, really, get back on track from their perspective. And then, of course, this idea of review the gap. Where are we now? Where are we going? And how will we get there? So just the gap itself sometimes can make a difference. Another idea is the small test of go slow to go fast. More and more testing cycles, and then making sure that we aren't abandoning the test too soon. One of the things that I've always told my students in our improvement advisor work is that there's a lot to learn from a failed test. And so it's really interesting in our improvement world, our first cohort of improvement advisors who were certified became the mentors, and then they became the faculty of ours. And it was so fun for me to watch them because they did a little skit to teach the newer students about how important it is to learn from a failed test. And they were really fun about how they taught. And so often there would be a little skit and how to learn from a failed test. So they were celebrating failures. Here's some more ideas. Thinking about I already mentioned ideas of people to do the work because those give you buy-in from now, and a little bit more about which ideas to start with. But also, one of the things that's helped us a lot in my health system is this idea of when you're doing tests with a group of people around, we ask them to let us know when it didn't work this time. So if it doesn't work this time, who should they tell? How should they do that so that we can get in there and test again? So, of course, the Ask Why 5 times would come in there. So why didn't it work this time? We want to know a little bit deeper, and then get their ideas. So always pulling in the ideas from the people who touch the process. And then if we can get them to check some of their ideas with patients and the families or carers, it gives the power to the test. And you can sit at the patient's bedside. You can go to maybe where a bunch of patients might come together to learn something together, like a cardiac clinic, a heart failure clinic, someplace where they gather, and then ask their opinion. It's amazing how many things these little groups of people, also just sitting in the waiting area where they may be there for 5 minutes or maybe a lot longer, but it's a time when they can see what you're working on and you can get ideas for them about how the patients might experience that. So I wanted to also bring in ideas about influencing others, and sometimes it's a little more difficult than for the usual people you work with. But first of all, this idea of bridging. So bridging means that when we want something from someone, that you start first with what's important to them. Now, this information was taught to us by drug retail people who were out trying to get their drugs in the front of doctors and others who may use the drugs. Now, those folks are kind of banned from our clinical settings now. They don't get to come into the doctor's office anymore or the hospital department, but this is how they actually made a difference. They sold a lot of product by using this method. So first of all, you start with what's of interest to the other person. So maybe you're asking someone to run a test. And so you say to them, I know you're very busy and would like to help them to find a little extra time to even have a cup of tea. So then you can talk about, once you address something that would be of interest to them, then you can talk of something that's mutual. And then after that, we can talk about what I'm asking you to do. So I know you're overwhelmed. We're trying to work on this XYZ, but now we also want to run one small test tomorrow. And so that just one test, you're not asking them to do this forever, but you're asking for one small test. Crucial Conversations, this book that would be available to you, begin with worry. I need you to show up. So, you could tell your executive sponsor, I know you're really busy and you're committed to our team's success, but I need you to show up for 2 minutes at our next meeting. Is that possible? Does it be that date, or can you come to the following date? Never use the word but because it negates what you're trying to say. From influencer, changing people's minds, certainly try to back yourself down if you find yourself judging, to use empathy. What might be going on in that person's life? Why are they behaving like that today? Just revert to kindness. I think motivational interviewing. If it's new to some of you, it uses non-directive questions that ask questions that help people decide what's most important to them, and it actually can help them move forward to, say, stop smoking or manage drug use in their life. And then this idea of just don't be telling, move to the asking side. And then make sure that we're engaging people in activities that help us quickly get to tests of change. So I'm wondering what else that you have been doing about these kinds of activities. How have you been engaging people? what are you doing for your own personal well-being? We hope that you're chatting in some questions, and I think we're ready to pause and see what you're thinking about. So please feel free to chat in more questions. Do they do raised hands?
Yeah, there's a few questions here, all right. So, a lot of it is around the same issue, really, of getting manager buy-in, or whatever you want to call it, but getting their backing in the organizations. Mary McKenna has asked about what is the best approach if the senior manager doesn't engage despite effort?
Well,
how do you maintain the resilience, and how do you keep going?
Right. So that could be very difficult, and I thank you for that question. So one of the things that I do is to try to find out where is this initiative connected to the strategic plan. Now, it may be vague. It may not be very clear about how it's connected. Actually, over time, I've learned that I'm not going to put my effort into it unless it's already at the outset clearly connected to the, and that may not be possible for you in whatever you're trying to accomplish right now. But if you can figure out the way that it would be connected, so what is the advantage for the organization, or what's the advantage for this manager to pay some attention for it? And then I think it's also gets clear about, you don't need a lot of their time, but you need to clarify the roles. Do you want me to continue to do this work? Because at some point, if there is no support and you don't know anyone that you should be having that conversation with besides that manager, so where did this initiative come from? And if it's it may be that there's a crucial conversation that happens either with that manager or around that manager. No.
And perhaps it comes back to another possible solution with the contracting. So, at the start of an improvement plan, that, everyone knows their role, and that the role clarity is laid out, and what the expectations of each other is clear from the very beginning.
Yes, and I think that what's often happened is that people fear that it's going to take more of their time. Now, do they not like the initiative, or what is it? So Edgar Schein, from the U.S., a profound man of great integrity and research, and he's also a prolific writer. He points out that in these cases, when people have this kind of like very strong negative approach to something, there's an underlying belief that is possibly even hidden from their ken, from their recognizing it as a barrier. If you can use some questioning to figure out why they are not into this project, then you have a better way to address it. So one of the things that I find is that, so Edgar Schein wrote the book Humble Inquiry, and I find that very useful to discover questions that can help us pull out. And in chapter 4, he mentions that and he's talking about research in the U.S., and I was just in Canada last week, and they said it's true for them too, so I'm not sure about Ireland. But what he said is that the problem with leadership over the decades has been that they value action. They value doing, not relationship. And yet they don't have a clear understanding that we get everything done through relationships. And when you're focused on doing, it's telling. And when you're focused on relationships, you are asking. So that there might be some insight in that book, Humble Inquiry, that could get you too. So motivational interviewing, if you know that, you might be able to actually use that in this situation as well.
Yeah.
Because it's what do you want from this unit, or what do you need? And so that may be it. So what I find is that often that people are so busy they just cannot deal with anything. And so can we get some waste and frustration out of the way first? And so I could tell you some techniques for that too, but that might be an idea.
Yeah. And that links in, I suppose, nicely into Emily Ennis's question. And really, I suppose it's talking about that QI burnout. And, we're all very eager to improve our services. And, we're all going to our managers with different ideas. So how can you deal with a manager who doesn't want to deal with issues when they're identified as future problems, but they prefer for the failure to occur and then resolve the issue.
They want to wait until it fails again?
So say if a staff member notices that there's a potential failure in the system, but it hasn't actually happened, and they want to put improvements
so it's
in,
potential.
but the manager's happy to let it go because it's
okay, all right, so here's how I do that. By the way, there is a 2x2, a quadrant, 4 boxes, that you can create a horizontal and a vertical axis that would help you take these ideas and put them in boxes. And so if you name the axis as easy to do and magnitude of harm, then so it's magnitude of harm that can get attention. So that's normally the approach I go to, is that if the likelihood of harm is high, then that can get their attention. But so you'd have to figure out the magnitude of harm that could occur when this happens again. So that may help you get to that. Otherwise, I'd need to know a little bit more of the context around the actual situation that you're dealing with.
And I suppose, you know, going back to the earlier slides when you talked about flourishing and reflection on the 3 good things that happens and how long it takes to mitigate that one bad thing. And I think people in services really are feeling that at the moment. There's a lot of pressure, you know, firefighting in terms of concentrating on the bad when we should be turning it into an opportunity.
Yes, talk to me. And so the other thing I would think is that, are you the only person who's worried about this, or who else is worried about this?
Yeah.
And to try to come together with some sort of a response that could make a difference. So think about that bridging technique that I mentioned, that first we think about what is the need of that manager, and then you can get to the point where you want support. It's not you want them to run a test, but you want support for that.
Yeah, great. Well, unless anyone has any other questions, we'll move along. We're nearly up on our time anyway. We have 2 more minutes, so anyone got any more burning questions, type them into the chat function, and we'll just click on. So, yeah, so we're going to move on then just to finish off, really. So I skipped on the slides there, but sorry now. Yeah, so basically our next QITalktime is coming up with Juanita and Libby, so you'll see the date there on the slide, and make sure to follow us on Twitter for any updates on further schedules. We have an exciting lineup planned over the next couple of months. We're just having some technical difficulties with the talks, but hopefully they'll be up online in the next week or 2, and also we'll put up some links. Some people talked about frontline ownership and the book references, etc. So we'll put up the presentation, if that's okay, Gail, and we'll put some links, useful links for people that they can join into afterwards. And so that's it really for now. So thanks everyone for joining, and anyone has any queries or feedback or any potential ideas for talks, I'd be very welcoming of those, so just email them on to me. And we'll see you in a couple of weeks for our next webinar with Juanita and Libby. Thanks a million.
Bye all.
Bye.